Hi, everyone. My name is Julia Wall. I'm the Director of Education at the Michigan Parkinson's Foundation, and we are excited about our topic tonight, palliative care. It is part of our virtual education series that we do monthly. Typically, it's the third Wednesday of each month. Before we get started, I had a couple of announcements. One, I just wanted to, for anyone that's participating in our Speak Out program on Fridays at 10 a.m. with Central Michigan University, we do have to cancel this Friday. I will send a notice out to our regulars, but if this was the Friday you were going to join us for our free Speak Out speech therapy at 10 a.m., it is canceled and will resume after the 4th of July. So we will, or I'm sorry, next week. It will resume next week. So I will send out an email and we will probably post something on social media, but it is canceled for Friday. Just a couple of upcoming events I thought I'd mention. Tomorrow in Ann Arbor at the Kensington Hotel, the University of Michigan Ann Arbor Parkinson's clinic, as well as the Michigan Parkinson's Foundation and the Parkinson's Foundation, are putting on a program between noon and 2. If you are looking for more information, you can go to our website or the Parkinson's Foundation and see. I'm sorry, you're right. Thank you, Edith. It's not tomorrow. I'm a day ahead. It's Friday. It is Friday, not tomorrow. Friday. Thank you for that. So you can, again, it's at the Kensington Hotel in Ann Arbor. I also wanted to mention on June 26th, the Davis Phinney Foundation and the Michigan Parkinson's Foundation is doing an educational event in Flint from 9 until 1 p.m. To register, you do have to register through the Davis Phinney Foundation website. And I believe that you had to register, they said yesterday, but I know that there's been strong interest in people attending. So there is an email that you can reach out to them on the registration page if you're interested in attending. And that is a free event as well. That is from 9 a.m. to 1 p.m. in Flint. I wanted to give another shout out for next month's virtual education series on Wednesday, July 24th. I think it's going to be a great meeting. We are going to have a panel of adult children of Parkinsonians. I think this is going to be a really good opportunity. If any of you have adult children that maybe don't understand Parkinson's or how they're feeling or how they're maneuvering this disease, it might be a really wonderful platform for them to learn about it and maybe even share their feelings. So all are welcome to attend, but that is going to be on Wednesday, July 24th at 7 p.m. Our walk season is upon us and people are very excited to participate in one of our four Michigan Parkinson's walkathons, our hero walks. The one in Metro Detroit is September 14th. And then we have one in Traverse City. We have one in Lansing and we have one in Grand Rapids. And to find out more about our walks, when they are and how you can participate, you can go to our website at parkinsonsmi.org and click on the support tab that will take you to the walk pages. And then you can click on each individual city to see which one you want to participate with. This is the largest fundraiser for the Michigan Parkinson's Foundation to help support a lot of our respite care grants, our medication assistance, our over 76 support groups throughout the state. So if you have an opportunity, it's a fun time. Do not let the word walk scare you. Please don't let it scare you. It is a social event. It's wonderful. And last year, I just have to give a shout out for the Metro Detroit Walk. It was amazing. Over 900 people showed up at Jimmy John's Stadium. It was such a day filled with hope and encouragement. It was priceless. So it cost $20 to register for the walk, and and kids are free, so you can bring your grandchildren. It's a lot of fun, and each venue is really nice, at each city that they participate. And then we have a couple of other programs that are going to be coming up. So make sure that you're getting our emails. Make sure you're following us on social media. We have a ping pong event that will be taking place in August. I'm going to be hosting a dueling piano program. It's called Dueling Pianos on Dopamine. That's funny. On September 22nd in Redford. And then a lot of other programs throughout the state. We're very fortunate today to be joined by Corinna Balentine, who is a nurse practitioner for a wonderful company that provides palliative care. I first came upon them last year when I was visiting in Traverse City. I think it's wonderful, the service that they provide.
Big sense.
And I'm going to ask everybody to mute if they can while we turn things over to our speaker. And again, remind everyone to please use the raise hand feature or unmute if you have a question. But it is my honor and pleasure. Thank you so much, Corinna. I'm going to turn things over to you.
Thanks very much for that introduction. I'm happy to be able to be here tonight and to present talking about palliative care. I'm very passionate about palliative care. I am a nurse practitioner. A little bit of background about me. I've been a nurse for almost 27 years. My background is in medical surgical, primarily really with stroke and telemetry, and then home care, and then now palliative care. So I've got a pretty extensive background and have come across many chronic illnesses, including quite a bit of Parkinson's disease in our area. Outside of that, I've been doing nursing type care for over 30 years. So a big portion of my history, my professional history, has been really in the nursing field. And I'm very, very excited to be able to talk about palliative care. I want this to be an open conversation, so please ask questions as we're talking. I don't have a problem with being interrupted. My system is a little bit wonky for me to be able to see things that are in the chat. So Julia, if you want to go ahead and speak up for people if they put something in the chat and ask those questions while I'm presenting, please feel free to do so.
Absolutely.
But I want this to be kind of a two-way, conversation. I'm not just here to orate the entire time. I want it to be something that's more of a conversation. So please feel free to interrupt. Palliative care. You get a lot of people who don't know what palliative care is, not sure what it means. I think it's, for a lot of people, a very scary word. And I think it's mostly because they just don't know about it. And that goes for people out in the community as well as, honestly, providers. I don't think that a lot of providers even have a full grasp on what palliative care means. Merriam-Webster's definition of palliative care is medical and related care provided to a patient with a serious, life-threatening, or terminal illness that's not intended to provide curative treatment, but rather to manage symptoms, relieve pain and discomfort, improve quality of life, and meet the emotional, social, and spiritual needs of that patient. I feel like that's a relatively good definition. However, I feel that in my practice, we've come up with a more comprehensive definition. Essentially, the same things that Merriam-Webster has, but it's treatment for a chronic illness, not necessarily something that's as scary as serious, life-threatening, terminal. Though we know Parkinson's disease is not curative, we can't do anything to get rid of it, but we certainly can help to manage it. And our goal in palliative care is to help to educate how to manage the symptoms, when to identify when something is progressing or getting worse, how to provide improvement in quality of life, as well as have those hard conversations about advanced care planning, including our patients and the families and everybody who's involved in the care, to help to meet those emotional, spiritual, and emotional, as well as the physical needs of our patients. What is palliative care is often a question that is asked. Essentially, from the definition, it is symptom management, promotion of quality of life, having a plan for as things progress, and to make sure that the rest of the time, however long it is, isn't spent just going to the doctor's office or working on treatment plans, but being able to be alive and enjoy life. That's really what we focus on in palliative care. We want to make sure that the symptom management for those chronic illnesses have interventions in place. People have things on hand to help manage those symptoms. Have conversations about how your medications are working. What are we doing if it's not working? Having absolute ability to contact and talk with a provider and have a conversation, rather than having to wait for an appointment, which might be weeks or months or something in advance. So the timing of providing those appointments and having those conversations is very important. And that's really what palliative care can help to do. It's that provider to be able to have that conversation about what's going wrong and how can we fix it and make it better. Quality of life and reduction of all of that time spent going to appointments is another thing that we focus on. If we can manage symptoms and we can make people able to do the things that they want to do, then they can also most likely do the things that they have to do as well. So our goal is to try and kind of find that happy medium. I want you to be able to, as a palliative care provider, to enjoy the time with your family, to be able to have those conversations and do those things that you like to do. We all know, as you know, as chronic illness kind of takes hold, we tend to lose control. Everybody's doing to us, and we don't have the ability to continue to do what we want to do. So oftentimes, that as a palliative care provider, my goal is to help navigate those conversations with families and with patients to promote that quality of life. And then advanced care planning. Advanced care planning are the decisions and the conversations about what do we do next? What happens when the symptoms get worse? What happens, or what do we do if I notice my medication isn't working as well as it used to? Or what does it mean when I'm seeing these symptoms? As a nurse practitioner, my focus is really on the entire person, not just the illness. You are defined not by what you have, you are defined by who you are. And that includes everything that's included in who you are, your family and the family dynamics that go along with it. Helping with advanced care planning and those conversations about when is it time to say when? When do we still work through aggressive treatment for chronic illness? When do we stop with the aggressive treatment? And ultimately, when do we talk about hospice? When does it come time for that end of life conversation to happen? My goal as a provider, the first time I meet somebody, is to initiate the beginning of those conversations, because as we can talk about what your goals are as a patient or a family or a group, it helps me to decide, and to help navigate all through that process as things change. Palliative care visit should include a comprehensive evaluation. That includes a comprehensive evaluation of medications, side effects that those medicines might create, any interactions that you might experience with medications. Oftentimes, when you have specialists involved in your care and a primary care provider involved in your care, they don't necessarily all talk very well together. And somebody might give you a medication to manage this symptom, but it really interacts with a medication that you take for this condition. And It's hard as a provider if you don't have all the information to be able to prevent those interactions from happening. It's my job as a palliative care provider to know all of the things that are being taken so that I can help to navigate whether or not the side effects or the symptoms you're experiencing are med effect as opposed to something related to your chronic illness. Palliative care really is something that is for anybody who has any chronic illness, and essentially to help manage those symptoms all the way through. Like I said, we talk about advanced care planning. That includes that do not resuscitate conversation or what type of treatment you want conversation. It also includes who do we have to help make decisions if it comes time where it's difficult to make decisions ourselves. It helps to have the family unit all understand and hear where everybody's coming from. It's, my job is to make sure that my patients are heard. It's really hard sometimes for children of patients with chronic illness to navigate mom or dad saying, I don't want this anymore. So it's my job as a palliative care provider to facilitate those conversations and to help guide through what direction we need to go. And then the goals for care. My first question is what are your goals? What is it that you want out of the relationship that we have? My job is to help to meet those goals. If it means I just want to get to my favorite place on the lake one more time, then we're going to do what we need to do to try and get to that favorite place on the lake one more time. It might take us a little while to get there, but that's where our focus is. And then symptom management, teaching about how to manage the symptoms, having medications or interventions on hand in case something pops up in the middle of the night or on a weekend or on a holiday, making sure that you're prepared and that the family is prepared to know what to do in an if-then situation. As a palliative care provider, I want to make sure that you're prepared and educated as to what it means when something progresses or something doesn't go the way it's supposed to, and what can you do to be a self-advocate and to be autonomous in that care. It's really my favorite thing to do is to give the power back to my patients, to be able to give them the ability to have some control when control feels like it's always being lost. I've had a lot of times when people say, when is it time? When is it time for palliative care? And what does it mean if somebody says it's time for palliative care? My opinion about palliative care is different than the general mainstream opinion. My opinion is as soon as you're diagnosed with a chronic illness, you qualify for palliative care. If you learn about your disease process, you learn about the symptoms that you're experiencing, you learn about how to intervene and alleviate those symptoms, then you are your best self-advocate as things change. You have the ability and the knowledge to be able to communicate that information to your specialists or your other providers and tell them, this is what I'm feeling, this is what I've done, and it's not working, or it is working, or I think it would work better if. So at the time of diagnosis for any chronic illness really is when people are qualifying for palliative care. When I say chronic illness, Parkinson's disease for sure, but that also includes hypertension, heart disease, diabetes, lung disease, kidney disease, neuropathy, somebody who's had cardiovascular or cerebrovascular disease like a stroke, anybody who's had issues with their heart, any of those things that are conditioned that we can make better, but it's never going to really go away. That's what a chronic illness is. And, at the time of diagnosis is the opportune time. Unfortunately, I think a lot of providers wait to introduce or have a conversation about palliative care until it gets to the point where they don't know what to do next. And then it feels like, from what I'm told by some of patients, it feels like they've given up. I don't know what else to do for you. So here, you go see this person who can just make things or placate things throughout until the end. That's absolutely not. That's not what palliative care is. We're here to help to manage symptoms, to improve and to promote your quality of life and to meet your goals. And that means while still doing curative or aggressive treatments, or when you've decided not to. Palliative care is also appropriate when your symptoms of your illness become problematic. So if we didn't get the referral at the time of diagnosis, then we should certainly be talking about the referral at the time when symptoms are starting to interrupt life. When you're unable to get out like you'd like to, or it's a taxing effort to get out and do the things you want to do, or you have just no energy to be able to get through that bridge game, or whatever it is that you're wanting to do is being halted or not attainable because of the symptoms of your illness. And then absolutely, when there's the progression of symptoms or when we've outdone all treatments that are available, then yes, palliative care it's time for that as well. So really throughout the spectrum or the time frame of, from diagnosis until the end of life, palliative care can be inserted or started at any point in time. It's my opinion, the sooner the better. You get an absolute opportunity to build rapport with the providers. You have the opportunity to really make the plan, make your goals known, have those conversations so everybody's on the same path. So any questions or anything so far that?
We do have a couple of questions that just popped up in the chat box. So the first one is, how do you manage care without being at appointments and hearing what the doctors are saying?
How do I manage care without being at specialist appointments? Is that what that is?
I think so.
So, as a nurse practitioner, I have the ability to diagnose and treat. I can prescribe medications. With my patients who have Parkinson's disease, most oftentimes they'll have a neurologist or a movement specialist that they are involved with, amongst other specialists. My goal is symptom management. So if I am dealing with somebody who's had a progression or a change in their movement, their Cinemed isn't working, it's not lasting as long as it used to, they're having issues sleeping at night. I work really hard to have a conversation with those specialists, whether it be I call them up in the office and have a conversation with them directly, or I do that communication within my note, which is a comprehensive visit note that's sent to them with their attention, so that I yell in face sheets on faxes. I say, attention, Dr. Robins, please read, or whoever it is, so that they are sure to receive that rather than just be put in a chart for them to maybe find. And, I find that the specialists want the collaboration. They want to have the conversation. I know that they're super busy and it's hard to get to everybody, and the appointments that you have literally are 5-10 minutes, and it's really hard to talk about all those things. I have the ability in my practice to have lengthy quality visits that really are for as long as they need to be. So I can gather a lot of information, and a lot of times I'm the eyes and the ears and the assessor for that specialist. So I relay that information to them and I say, these are my recommendations. And 98% of the time they agree with me. There is that 2% or 5% or whatever that they say, nope, I'm going to do it this way. And, and that's unfortunate. But because I have the ability to diagnose and treat, if there's a symptom or a problem, I can intervene now. I can say, let's go ahead and increase your dose right now. I'm going to send this off to your neurologist, and we're going to have a conversation, and maybe they'll make a change in those medications. I have been known to go to a specialist appointment with a patient. That's not something you would typically have many providers do. I have many specialists that communicate to me directly and ask, what are you seeing when you see them? Because they know that my visits are more involved and lengthy, and I have a larger portion of time to be able to see and visit frequency to be able to identify. Hopefully that answered the question.
It did. I think that was helpful. There was another question, two-part. Do I need a referral from my primary care doctor to see a palliative care provider? Does insurance cover? And do you come to my house or for an appointment, or do you have an office? How does that work?
Well, that relays me right into my next slide, which is about coverage. So yes, palliative care is covered by insurance. It is covered just like any other specialist visit or any other primary visit. Palliative care practices amongst the state are all a little bit different. I'm in Traverse City, and I'm talk about my service area a little bit here, future in the conversation. But our practice does do house calls. That's what we do. We go to our patients. I don't know that there are many practices that do palliative care in the home. A lot of times it's a palliative care clinic where you need to go into the clinic to see the provider. That being said, everything that I talked about, the comprehensive visit, the medication reconciliation, the advanced care planning discussion, the promotion of quality of life, all of those things really should be the same, regardless of that location of that visit. But either way, yes, whether it's in the home or otherwise, palliative care is covered by insurance. It is a separate benefit from hospice. So services can be provided until the end of life, even when hospice is engaged. So you can have palliative care and hospice together. In my practice, we prefer to certify hospice care because we've already established a relationship with our patients. We already have rapport. We've already done certain things, and we'd hate to have to recreate any wheels if symptoms progress. So, we work along with the hospice agency when it comes time for hospice to help kind of move our patients and the hospice agency through the process. So there are different benefits. They can certainly happen at the same time. If you are in palliative care and you want hospice or you need hospice, it doesn't mean palliative care has to go away. You don't necessarily have to lose that provider. And then, while having palliative care in place, your primary care providers and other specialists can certainly continue to provide the services that they've been providing. We encourage, if you have a good relationship with your primary care provider, to keep that primary care provider. There's no reason not to. We just typically we tend to take over the frequency of visits in that specialist or that primary care provider. So you would go and see the specialist on an annual basis or semi-annual basis. You would see the primary care provider on an annual basis, and you would see us for any other time frame. I hope that you can't hear my dog whining in the background. I'm really sorry. Okay, good. She is being a little bit ridiculous right now.
You're good.
So, yeah. So having the opportunity to have the other specialists involved, the communication is important. We are sure to share our notes with those specialists and those primary care providers in our practice because we want them to know what we're seeing. We want them to know the interventions that we've done or the problems that are occurring. We want to make sure that we're communicating that information. And Palliative is the name of the practice that I own. I have 9 nurse practitioners out seeing patients in their homes currently. We service 8 counties in Northwest Lower Peninsula. So we are Grand Traverse, Leelanau, Benzie, Wexford, Missaukee, Kalkaska, and now Charlevoix. So really, this corner of the pinky is kind of where we're at. We don't have the ability to provide services from our practice much further than that. Our home office is Traverse City area. We certainly know that our services would be valuable, several other places. I just can't be in more than one place at a time, unfortunately. Palliative care is something I think that is growing. I feel like our home-based services that we provide, we are definitely ahead of the curve in the realm of provision of this type of service. I do know that there are other practices that are really trying to do what we're doing. They're trying to move into my space, but I know that they're downstate as well. You know, when I Google palliative care, I get a lot of hits with primarily saying hospice and palliative care. So they're kind of pairing the two of them together. And my hopes today is to make palliative care not seem quite as scary as I think that a lot of people perceive it. When palliative care is offered or palliative care is spoken of, it really is promotion of quality of life and the opportunity to better manage symptoms, and not it definitely should not be a, you know, we've done everything we can do, there's nothing more. If we can focus your quality of life moving forward to be what it is that you want to do rather than having to do a bunch of things that you don't want to do, that's really what palliative care is. That's really where that focus is.
We had another question.
Okay.
How often would one see you as needed, or is there scheduled visits set every so often?
For us, our cadence, we like to see our patients on a monthly basis. That's a lot more frequent than what you're used to seeing your specialist or your primary care provider. But because we come to them in their home, we do want to see them on a monthly basis. We can certainly stretch that out 4 weeks or 8 weeks, depending on, you know, the stability of symptoms. But the reason for that frequency is we can often catch something, those little nuances, those things that might happen just before they become problematic. You know, my goal in that promotion of quality of life is to limit or prevent those trips to the emergency room, the things that end up ending with us going to the hospital and having hospital stays. Those of you who've had experience with any Lewy body type dementia or dementia in chronic illness, you know that being in the hospital is not a good place for somebody who's already has an altered perception. Definitely makes things not good. I worked in the hospital for 15 plus years. We tend to break things when people go to the hospital. They go in relatively well and they come out a little bit better for whatever the acute process is, but not necessarily better overall. So, you know, follow up from hospitalization in a timely manner and those frequency of visits to try and prevent those trips to the hospital is really what our goal is. You know, those home visits by nurse practitioners inside our practice, like I mentioned, there's 24/7 access to nurses. So having the ability to call and speak to a nurse any time of the day or night is part of what our practice is. And then, like I said, prevention of hospitalization or trips to that emergency room with the patient goals as being our focus for care. Certainly, if every month seems too much or is too overwhelming, then we definitely adjust that cadence to fit the patient's independence. But we do like to see more frequently, and the reason is to be able to catch something before it becomes a problem.
Corinna, can I share something about?
Absolutely.
I just want to give an example of someone I know who they would see their neurologist every 6 months. And with Parkinson's, you know, it is a relatively slowly progressive disease. So every 6 months might be okay. And it might be okay for a while. But things come up, and oftentimes the communication is bad between, or not bad, but maybe just not as ideal between the movement disorder specialist and the primary care doctor. And you might have a symptom come up, and the neurologist may say, contact your primary care, and you call the primary care office, and then they say, no, it's probably Parkinson's, call the neurologist. I mean, it's like a tennis match sometimes.
Mhm.
But I do know someone who actually entered in palliative care And they did get home visits. Um, I think they were, I'm not sure. I think it was with University of Michigan. I'm not sure. I know all of the major hospitals have some form of palliative care, but I don't know to the
Mhm.
extent of their programs. But what was great is that this person was having a lot of confusion, delusions. They thought it was medication related. So they went through so much of changing this med, doing this med. And the palliative nurse caught that the patient had a urinary tract infection. And now they were prone to these urinary tract infections. And going back to see the doctor every 6 months isn't enough to see if you are free from urinary tract infections. And it was a
Right.
life changer in this palliative care situation for someone, because when you call and they go, well, I'm confused, or my spouse is confused, and there's nothing wrong here, call your primary care. Primary care goes, no, that's definitely the Parkinson's. It was neither. It was a urinary tract infection.
Right.
So I just wanted to share that story because I think that's one of the most ideal situations, given the fact with people with Parkinson's and access to their movement disorder specialists is usually about every 6 months.
Hmm. Yeah.
Right.
And it is definitely easier to catch those nuances, those things that change, if you have more opportunities to see somebody as a professional. For me to see a patient on a monthly basis, I know what things look like, sound like when they're well, and then I know really well what things look like and sound like when they're not. And honestly, anytime there's a change in mental status or a change in strength, increased weakness or increase in falls, you would think with Parkinson's, oh, they're falling more. Well, that's easy for a primary care provider to say, oh, well, that's the Parkinson's. And, but it probably most likely isn't necessarily, especially if it's an acute change. If they weren't falling and all of a sudden they are, I mean, that's the first thing as a palliative care provider we think about is, number one, is it metabolic? Is there something going on in the body that's causing these things to have changed? And then number two, is it medication related? Has there been a recent change in the medication? Something that has chemically caused, the ability for something to change. And then if we rule out all of those things and it's not metabolic and it's not medication, then we go to the step of it being the chronic illness or whatever it is that might be in a progression of the disease process. So not to say that other providers don't do that as well. I definitely don't want to sound
Right.
like, what we do is so much different or better than what other providers do. But I definitely concur that it is easy for there to be this kind of a turf war. I'm going to hand you off here, or I'm going to hand you off here, because they, rather than take the time to hear about what's changed or how things have changed and to try and do an intervention, that's really where we definitely come in a palliative care situation.
We have a couple of questions coming in. If you would like me to go ahead with
Certainly.
those, or
Absolutely. Yep.
all right. So one of the questions was, do you know or have any knowledge on Medicare coverage for palliative care, like straight Medicare?
Absolutely covers. Yes.
Wonderful, great.
Yep.
Someone was asking if we know of any company similar to yours in the Ann Arbor area. I just know that, and you can answer that, Corinna, but I know that U of M does have a palliative care program that is home-based and a clinic, I believe.
Okay.
But that is as much as I know.
Yeah. And I don't know the extent of those home-based visits. I don't know if it's a primarily home-based practice or if it's, only a certain number of visits are in the home-based situation, or you have to go to the clinic a certain number of times. I'm not exactly sure how other practices have things set up. But
But
I
would
do agree with you.
say,
Most all hospital systems have some sort of palliative program.
So would you say it's safe to say if it's something that you're interested or thinking about, that that's the conversation with your primary care or your neurologist
Absolutely.
and get a referral from them? Yeah.
Absolutely. So for my practice and most insurances, honestly, I don't need a provider to refer.
Mm.
You can self-refer. So if there is uh, a provider that does palliative care, I would encourage you to call. If you find a practice that you're interested in your area, I would encourage you to call them and ask them if they require a provider to refer for those services. Um, because, you know, in our realm and the specialty that we provide, um, that's where we probably are closest to hospice, because people can self-refer to hospice as well. They don't need a physician to make that decision per se, to say that it's time for hospice. People can make that decision themselves. They can say, I want hospice, and they can call a hospice agency and have them come out and do a visit. That hospice agency then does an evaluation and determines whether or not there's qualification, and then we'll reach out to a provider for an order, so to speak. That being said, insurance coverage for our services is not dependent on a physician or another provider's referral to our services for that. So you would have to, though, call whatever practice that has palliative care in your area, and ask them specifically whether or not they require a physician referral. And then, yes, please have that conversation with your primary provider or your specialist, um, to get that referral if that's what's needed. I want to go back and clarify insurance a little bit. So traditional Medicare Advantage plans, a majority of them provide or cover my services as a palliative care provider. Deductibles, copays apply like any specialist would be. I always encourage people to call their insurance companies to determine whether or not they have, or they would consider that provider doing palliative care as a specialist or otherwise. And that would tell you whether or not the deductible is a higher end deductible or just like a routine visit deductible, or excuse me, copay, if there's copays involved. But yes, traditional Medicare, straight Medicare absolutely covers the services that we provide. I see lots of things in the chat. Is that
Yes.
lots
Yes.
more questions?
Yeah, I just wonder, do we want to stop sharing your screen and bring up are you done with your present? I don't want to be rude. Are you done with your
I
presentation?
am.
Oh,
The
there you
only
go.
the last one I have is, that's my last slide. Basically, this kind of is a statement or a quote that really kind of in a nutshell covers what palliative care is, we can't change what happens in the end, but we certainly can make the journey a better journey. And that's, that really kind of hits home for me. That's really what my job is. That's what my role is to improve the journey. That's really what palliative care does.
Oh, that's wonderful. Thank you so much, Karina.
Oh,
This is great.
absolutely.
So I'll just start reading some of the questions off.
Absolutely. I'm
During
going to
that
try to
monthly
stop
visit,
sharing.
you should be able just to close it out, but I can also try in my end. During that monthly visit, do you provide medical services or is it more planning observation services? For instance, my husband with Parkinson's needs a catheter change every month that currently home health nursing is providing.
So my practice doesn't do the monthly catheter change. We also use home care agencies to help to manage that. We do provide medical services, however, in our visits. So our typical appointments would be doing an evaluation, medication reconciliation, kind of doing a follow-up on how things are going, what's most recent, if there's been any changes, intervening on any acute changes, something that's new, illness or otherwise, and following through with a visit, no different than if you were to go to your primary care provider. That's really kind of the gist in a nutshell, what we do on our visits. Sometimes we'll do wound care incidental as we're there. We are nurses, so if we're going to look at a wound, we're going to redress the wound. Sometimes if there's been an issue with a catheter while I'm there at a visit, I will intervene and do what needs to be done. But for the general management of that, we do utilize the home care services. And the reason for that is inside that Medicare payment for those services bundles that the supplies that are needed for the catheter changes, as well as the supplies themselves, the catheter, the collection bag, the tools that we need to provide to do that change. Those are all things that are kind of encapsulated in what the insurance covers for that home care service. So if I were to do that, then it would be on the patient's dime, so to speak, and the cost for those things are more out of pocket.
I know we've had a lot of questions about where can I find a palliative care in Southeast Michigan or in my area. I think that really having that conversation with your primary care doctor or your neurologist is really good. But also you can certainly do some Google searches, but check the reviews. One person asked about North Star palliative provider. Is that through U of M? I do not believe they are part of U of M. I think they are an independent company. Most palliative care programs, if they are tied in with a hospital, they will be on their hospital website, and you can just type in, like, for example, Henry Ford palliative, and it should go to their website and tell you what kind of palliative services they offer. The same with Corewell Health or U of M.
Yeah. I do think the North Star Palliative Care is a program that Hospice of Michigan created.
Yes.
And goes along with the Hospice of Michigan program. I don't know what they provide down in the Southeast Michigan location as far as visits or otherwise. I do know that up here in our area, that program isn't a comprehensive palliative care program so much as a provider that helps to that comes in and visits on a semi-routine basis and just kind of helps guide the process. They don't do a lot of medical interventions or even acute illness interventions in our area. So it might be something different in the Southeast Michigan area.
And I think that you brought up a good point, Corinna, about like a lot of people associate palliative care with hospice. And in my opinion, and in my medical career, palliative care just was never really much of an option. It wasn't talked about that much. And now I do feel like it is definitely gaining in popularity. And where I've seen it try to take off has been a lot of home health cares that have already provided home health care. Then they perhaps offer hospice, and then they offer palliative care as well.
Right.
So I know residential home health, and someone had commented, yes, actually Dr. Borklor said that she refers her patients to residential hospice because they have a palliative care branch. And they've been very happy. I think residential home health as a whole and residential hospice, they've done a good job in South. They're actually throughout the state now, but they've done a really wonderful job with our Parkinson's constituents. They've reached out to the foundation. They've gotten a lot of education, a lot of support. So I think that's great. Let's see. I got more questions. My husband was referred to palliative care from a social worker we were working with, and our nurse is affiliated with a hospice agency. So a smooth transition when the time came. And they are not hospital based. That's great. Shelley, do you want to shout out? Because you're in Southeast Michigan, the company. Except you have to unmute yourself.
Mute. They are, I believe it's called Michigan Healthcare. Associates. I know they're based in Farmington Hills. We've had a couple of great nurses come out at different times. They come out once a month. And usually everything's pretty, pretty stable when they're there. The crazy things happen, in between visits, of course, the hospital visits and all that. But we were referred, I had contacted Jewish Hospice and Chaplaincy Agency for some guidance several years ago. And they because I just had questions and didn't know where to turn. And they put me in touch with this palliative care agency.
Yep, and
So
it's called Michigan Palliative and
believe
Hospice
it's,
Care.
hold on, I might have a card right here.
I've got their information, Shelley. Michigan Palliative and Hospice Care, and they're located on Northwestern Highway in
Yep.
Farmington Hills.
That's them.
Okay. And you found it very helpful, Shelley?
Yeah, I mean, he comes out if I needed something at one point, and I sent the nurse a text. It was about a medication that needed an adjustment, and he texted me back in 5 minutes, all done, taken care of. So I haven't. My biggest issue with them in the beginning, and I think we've stabilized now, is we would have the same nurse for 3-4 months, and then all of a sudden the nurse would change. So the continuity kind of upset me. And then we had another nurse for a couple months, and then they're very active at Beaumont, Corwell, Royal Oak, as far as providing palliative care and hospice care there. And so what was happening were these nurses were going into the hospital and not doing outpatient care anymore. So, but the nurse we have now, and it's a male, which is nice because I think my husband kind of, they chit chat. It's a little different, relationship because he's talking to another guy and they can talk their sports or whatever they want for a few minutes. And he said he's staying with the home palliative care, that he will not be going to the hospital. So I'm grateful for that. I hope, it stays like that. But other than that, I mean, I haven't had a problem with them. So, and again, they're not a hospital owned practice.
Yes. Thank you, Shelley, for sharing. I do want to get to a couple of other comments here as we're running out of time. One, someone asked if this will be recorded. Absolutely. This is being recorded right now, and it is going to be available on our YouTube channel. So you can certainly watch that back or share with anyone. Also, Karen asked to drop the name of the company in the comments, please. Do you mean Corinna's? Let's put Corinna's in. That's NP Palliative Care in Traverse City. And then I can put the other one that Shelley was just talking about. And then again, like I said, there are a lot of other places that you can check out. Isn't it terrible if they don't have spell check on the chat part? Okay. Then Dr. Borklor is on with us watching tonight, and she stated that, may I say that most of my Parkinson's patients get to palliative care too late. They can always get an evaluation, but they don't always need to sign up. The same for hospice. So many times hospice comes in too late due to too much stigma against hospice. I couldn't agree with you more on those statements. I know when they mentioned the word hospice with my dad, I didn't want to hear those words. And I was very much against it because in my mind, hospice meant you're just going to go, the day you sign up, you're going to die. And this was a long time ago before all the hospice rules changes, but there's not an expiration date on Parkinson's disease, right? We don't know.
Right.
You aren't going to die from Parkinson's. You might have a related issue, but it's not going to be the Parkinson's that kills you. So my dad was in hospice care for 6 years, 6 years out of his 45 years of having that diagnosis. And he was really in hospice because he had prostate cancer. And that's eventually what took him. But I agree with you. I think people need to get signed up in palliative care sooner, particularly now in this healthcare crisis where we don't have enough doctors. Your visits are so far apart. To have that captain of the ship make sure that all of the soldiers are on the same page, I think is priceless. And that's just my 2 cents. Anybody
Care
have
Oh, I was just going to say care coordination is a very, very big part of what palliative care does. You know, I like to be able to communicate the information, the medication changes to the other providers that are involved in the care and to help direct patients and family members and, you know, what to make sure that they mention to those providers when they have those visits. So I appreciate that input and absolutely agree that palliative care is definitely started way too late by specialists and by primary care providers equally. In our area, you know, the palliative care referrals that we get from specialists like pulmonologists and cardiologists are really at the point where they've decided that there's nothing more they can do. And, you know, that's unfortunate because I think that there's a lot that palliative care can do for all the chronic illnesses in helping to manage those symptoms and to educate patients and families on what to look for and what to report and how to report.
Yeah, I agree. Does anybody have any questions? You can unmute yourself or any comments.
I have a quick question. My dad is part of the Michigan Parkinson's Foundation because he has Parkinson's, but I was told that palliative care, my mom she's his primary caregiver. She has diabetes. And I was told that diabetes is also a coverage under palliative care. Is that correct?
Absolutely.
Wonderful. Thank you.
Absolutely. Yep. Diabetes has, if not well controlled, can affect every organ system in your body. So yes, absolutely.
Yeah, and unfortunately with the stress that she's going through with caretaking for my dad, it's throwing her sugar out of whack.
Of course, yeah.
Right. Thank you.
I'm just curious why the neurologists don't promote this in the beginning when you go to see them. I mean, this has been a very helpful presentation for me. And I just can't understand why the neurologists aren't promoting this.
I don't have a way of responding to that to know exactly why there aren't more referrals. I think that I would have to say it leads mostly to just lack of knowledge really about what is provided in palliative care. And palliative care has been around for a long time. It has not been utilized the way that we utilize it or the way that a lot of other practices are beginning to utilize it for a long time. You know, our practice is 10 years old. We started our practice after the hospital system started our local hospital system started an at-home palliative care division that they did for about 3 years and then stopped doing because they felt it wasn't a profitable avenue for them. So they went to a clinic format as opposed to an in-home format. So, you know, in the world of healthcare, palliative care really has only been more present in, I'd say, maybe the last 10 to 15 years. So it's education and trying to get these specialists to identify that it's not an, you know, last hope scenario or situation where we do the referral, but when the diagnosis happens to help navigate all of the things that families and patients go through.
Dr. Borklor has some insight she wants to share. Dr. Borklor?
Hi, everyone. So yes, working with the neurologist every day, I can give you some insight on that. I'm actually a geriatric psychiatrist, for those of you that don't know me, and half of my time is spent in the Department of Neurology at Henry Ford. And I can say that in working with a neurologist and working with other psychiatrists, it depends on your training and it depends on your culture. So at Wayne State, we were taught to take care of the whole patient. So part of death and dying was part of our curriculum. Chronic diseases were part of our curriculum. And then when you do a psychiatry residency, the whole person and all of their psychosocial issues get rolled into the medical aspect of taking care of patients. Family medicine is another one that takes care of the whole patient and rolls all of the psychosocial stuff into the medical aspect of diseases. Every other specialty, and I will throw them under the bus, is very disease focused. So working with a neurologist, if they can't fix it, they turf it to me. And I'm like, I can't fix it either, but we can manage it, we can make it better. So I'm usually the one that calls for hospice when the caregiver is too stressed out, when I am at the end of my rope with medications and treatments. So that's part of it. Part of it is cultural, is in America, stereotypical white Americans don't call for hospice because hospice means giving up. But in Asian cultures, you never put your loved one in a nursing home. If you put your loved one in a nursing home, woe to you and all of your descendants. So many other Asian cultures will incorporate hospice or palliative care earlier because that's a family thing to do. We take care of the family in the home. So it's a very complicated answer to how and why not is this done sooner. Thankfully, the medical schools are incorporating hospice, death, dying, and how to manage chronic diseases into the medical school curriculum. I know that when the psychiatry and neurology residents rotate with me, this is a big discussion. And I tell them you have to get comfortable with palliative care and hospice because the population is aging. We're going to need their resources. There's not about enough of us, and not everything can be cured. We can manage it, we can make people comfortable, but they have to get comfortable with doing it themselves too.
That was excellent, an excellent explanation. I think that is absolutely true. And I think also sometimes it's just creature of habit. You go in and you see the doctor and they say, okay, come back in 6 months. Call me if you need me in between. And then, I think the challenge that we have right now in our healthcare system is not only access to appointments, but access to conversations, phone calls, and emails. When you need someone, not in 48 hours, right? So
I would also say on the line of, I don't want to interrupt, but I
No.
want to get this in real quick
Yeah.
before we run out of time. Along the line of culture, the generation that is our elderly population right now are not those to challenge or to go against somebody in authority, and they perceive all physicians or providers in that realm of authority. So when they're not given an option or not talked about, these are the things that could happen or you might have access to, they don't know, they don't self-advocate well, I guess is what I'm trying to say.
Mhm.
Their children, their children's children are very much more in the self-advocacy realm. The culture is that I need to know what I have access to and I'm going to search it out or find it. And that's where, I would challenge the children and the children's children to be those advocates for your parents, your grandparents, to challenge the providers a little bit and what else is out there or what don't I know about, because that can help to educate those providers as well. I would love to be able to stand up and say, hey, I'm here. Look at me. But it doesn't always work. They don't always listen. So hearing it from the patients, hearing it from the families, asking those questions, challenging those providers to do those referrals, engaging the conversation, I think is definitely an appropriate intervention that everybody can do.
Well, I know we're almost out of time, but I want to make sure that I get in a comment by Vicky. Vicky, can you unmute? No. Well, if she can interrupt me, but I will speak on her behalf. Talking about support for the caregiver, very important. And that now in this day and age, particularly post-COVID, you can get support from being online. If you can't attend in-person meetings. The Michigan Parkinson's Foundation, we have many virtual meetings available, Detroit, Grand Rapids, Lansing. And then of course we have in-person groups all throughout the state. It is important to make sure that the family and caregivers are supported through this process as well. Nobody can do this alone, no one. I'm grateful to the people who have reached out and said that they appreciate this presentation, that it's been helpful. And I think that it's maybe the first of many that we can do to really get the word out and let people know that this is a helpful service that's available to people, and we'll see this service grow. So with that, again, I'm going to make sure this is up on our YouTube channel. Thanks everybody for participating. Oh, yes, they would love more Zoom calls like this. You got it. It was such a great informative talk, Corinna. Thank you so very much. Hopefully we'll have you back again. And
absolutely.
And you'll be hearing from me soon as well.
Great.
Okay.
Great. Thank you.
Thank you.
Thank you. Everybody stay hydrated, stay cool. Take care.
You too.
Bye-bye.
Bye-bye.